This is a paid advertisement from BetterHelp. Stress and anxiety affect all of us, whether it's the daily pressures of work, life, or the unexpected moments that throw us off balance. So as pre-hospital professionals, we see firsthand how mental health can impact lives, yet sometimes we often neglect our own mental well-being. So anxiety can manifest in ways we don't always recognize, that of headaches, sleepless nights, or feeling just constantly on edge. So in a world that demands more, sometimes the best thing we can do is just pause, reflect and seek support. Therapy isn't just for those in crisis, it's about learning coping strategies, setting boundaries and becoming the best version of yourself. So BetterHelp is the world's largest online therapy platform, connecting you with professionals who specialize in anxiety and more. So take control of your mental health today. Our listeners get 10% off their first month at betterhelp.com/carepod. That's betterhelp, HELP.com/carepod. That's CAREPOD. Please see the show notes for further details. This podcast is sponsored by PAX. Whether on the water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Their well-organized compartments and customizable configurations enhance efficiency in high-stress situations. They're designed with infection control in mind and are easy to clean and disinfect. So highly visible colours and reflective strips aid quick identification and adherence to quality standards, ensuring reliability. So the versatility of PAX bags caters to diverse EMS providers, and they deliver vital equipment, durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations, and they're absolutely excellent, both in identification of kit, but also in identification of the reflective strips to ensure visibility. So please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking about pre-hospital resuscitative thoracotomy with Mike Christian. So we're going to look at pre-hospital thoracotomy for traumatic cardiac arrest. And in this episode, we're going to dig into a recently published study in JAMA Surgery. The senior author was Dr. Mike Christian. So this study really looked at the impact of thoracotomy in the pre-hospital environment within London's air ambulance. So a system with over 2 decades of experience in this procedure. So traumatic cardiac arrest is often seen as a condition with poor prognosis, but for selected patients, particularly those suffering from cardiac tamponade, pre-hospital thoracotomy has been shown to improve survival rates when performed within minutes of arrest. So this is the largest study of its kind, analysing over 600 cases and shedding light on the effectiveness of thoracotomy, the time-critical windows of intervention, and indeed the factors that influence outcome. So in this study, we're going to explore the study's key findings, discuss the operational and ethical challenges of performing thoracotomy in the field, and also consider what it means for future of practice and trauma care. Welcome to the podcast, Mike.
Thanks, Owen. It's great to be back again so soon.
I wonder if we could just start, Mike, and just really look at indeed the rationale. So what prompted this study on pre-hospital resuscitative thoracotomy for traumatic cardiac arrest? And indeed, why was London's air ambulance chosen as a study setting?
Yeah, so I think 2 reasons. One, there's sort of the scientific sort of methodologic rationale behind it, and that, this is a piece of work in area that London has innovated in for many years. It was the first organization to do pre-hospital resuscitative thoracotomy with the clamshell back over approaching almost 30 years ago now. And so there hasn't been an update in the data from that group for a while, but there's also for me, a personal story that really drives sort of why this was done, and it goes to why I joined London's air ambulance in the first place. And in 2015, I was visiting London to attend a different conference, saw there was a pre-hospital conference, so I thought I'd stop in. I was a mid-career intensivist in Canada, working in having been a paramedic before, now working as a sort of medical leadership role in a air ambulance system. And it was a classic sort of, at the time, although it's changing now, North American system of primary paramedic response. And, in the service at the time, we were getting to the point where there was discussions and decisions being made about not even dispatching to traumatic cardiac arrest, launching the helicopter because it was felt to be futile and there was such poor outcomes. Was it either cost effective or triaging between the demand? Was it worthwhile to dedicate a team to that? So I was in London for this conference, sat there for a day, had a really interesting conference. There was this young man sitting next to me throughout the whole day. I was sitting at the very back row, kind of felt like a bit of an interloper into this world of pre-hospital care in the UK. And we chatted. He was just finishing his first year or first semester of engineering at college, and really nice guy. Seemed bright and energetic and enthusiastic about life. And then at the very last talk of the day, I realized that this guy who I thought was a volunteer med student or something, or volunteer helping out with the conference, he's on stage at the front, and he lifts up his shirt and reveals his thoracotomy scar. And just over 6 months before, he was lying dead in a parking lot, had had a stab wound to his left ventricle, and the London's air ambulance team came, did a thoracotomy on him, resuscitated, treated his tamponade, and now not only is he a survivor, but he was thriving, and that blew my world. And I was like, I need to understand how they're doing this, what they're doing, everything I saw about the clinical governance there that day and the whole process, and it completely transformed my view of what outcomes can be for traumatic cardiac arrest, and that led me to come to London for a sabbatical that ended up lasting 6 years. And that's what for me was wanting to get this information out to the world again, update it, and really to give back to what London's Air Ambulance has given to me and how it's changed my career and my view about clinical medicine.
Yeah, listen, that's profound, Mike. And like you said, those kind of experiences are revelatory, really, in the fact there is a survivorship in a certain category of patients. And I think what we'll do is really look at that, because there is walking examples, as you said, of patients which have had profound focal injury, tamponade type injuries, which do leverage this procedure, and we'll focus on that. What I'd like to do is really look at the study, because it is unique. There is nowhere else in the world which has got, or indeed no other study which has got such a large recruitment and data set. Could I get you to speak to initially just the scope and methodology? If you could just outline the scope for us, and then maybe the inclusion criteria, how cases were selected, and indeed maybe some of the challenges you encountered whilst conducting the study.
Sure. So really, this is building on the work of, that Gareth Davies and David Lockey and the other, founders of LA did. And it was really a case series that was intended to look at every thoracotomy that was done in the past 20, ended up being 21 years of London's air ambulance practice, because we recognize that clinical medicine has changed over time, the introduction of blood and some other innovation in terms of the system. So we wanted to look at that. It was all cases that were pre-hospital, and that is interesting to really define. We said it had to be outside of a structured sort of healthcare facility, because in the process of doing this work, I realized how many times, especially in the early days, London's air ambulance teams were going and doing thoracotomies in other emergency departments and things before the trauma system was as organized as it is now. So it was just the pre-hospital teams, pre-hospital cases, and it was really every case, going through and trying to make sure we captured all of it, and then as much follow-up and as detail as possible as we could.
So what were some of the key challenges that you encountered whilst conducting the study?
So a couple of big challenges. One, which has really changed my practice, is documentation. So recognizing the variability in how people document, and how much that matters to be able to learn from these cases down the road, because there'd be some patient care reports that would literally be came, saw, did thoracotomy, left kind of thing. And then there's other cases where people like Zane Perkins and others that would give diagrams on the back that were Netter's level of illustrations of where the wounds were and how they were sutured and everything. So there's that variability in documentation, which is a challenge. And that led us with the new EPCR that was introduced into London's Air Ambulance to just very specifically structure and design a way to capture data so it's much easier and going forward, and we capture all the key elements, but not a lot of extraneous details. So that was one thing. The second thing, which was an unexpected challenge when I joined London's Air Ambulance as the research and clinical effectiveness director, was they had a database with all this data from that point, almost 30 years of the organization. And because of a failed database transfer, a migration hit by the middle of a cyber attack that I think you remember happened across the NHS, it was impossible to get any of this data from the 30 years out. So we had to address that and brought on board Christine Henry, a fantastic data scientist, and Liz Foster, the nurse there, to work through how to do this. And then in the end, we found out there were 5,000 cases, just over 2.5 years, that even though we had the original records, we lost all the metadata for them. It wasn't couldn't be recovered. So we had to get together a group of people, Shad Aziz, Andy Whitehouse, Steve Reed, Rich Carden, Rob Grenholland, who had to go through and initially comb through those 5,000 cases by hand, which Shad and I did, to recategorize them, and then get this team to go through and manually extract the data from all of these, all the cases, so we could get the richness of detail. So that is definitely a challenge. And I think one of the things that hampers this type of research in so many pre-hospital care systems, and also to encourage people who get frustrated with EPCRs and stuff like that in the clinical day-to-day world, that it's worth persevering, because in the end there's some benefits that can come from allowing us to learn more and faster from cases.
So looking at the key findings, Mike, could I get you to speak to some of the key findings of the study? Namely, one thing that struck me was, bringing the intervention forward in the trajectory of care for pericardial tamponade, and maybe as you stick the ultrasound probe on, or indeed you've got the wounds there, you've got maybe confirmation from the ultrasound. Could I get you to speak to the key findings that really emerged from the data?
Yeah, there's a couple, and I think we'll probably talk a little bit more about this later when we get into how we use this down the road. But the one thing is that speed is of the essence for the patients, particularly in tamponade. And in those patients, we found that if they had a resuscitative thoracotomy within 10 minutes of arrest for cardiac tamponade, they had a 40% survival, which is remarkably high. Overall, for tamponade, it was a 21% survival in the study. And then, but the other key thing is really looking at, really for patients with a sanguination, how poorly they did. So only a 1.9% survival, and really starting to shift our thinking around the how to treat that group of patients. So those are some of the key findings. We really need to think about how we get people there faster, and how we address the timely delivery of the intervention in tamponade. That's the other sort of key piece that comes out of this, and then really thinking about our decision making. And I think we can touch on that maybe more in a minute, but getting into physiology and using that to guide our decision is really, I think, one of the other key takeaways is reframing how we think about these conditions.
So could I get you to speak to that? Because I think, like you said, it's very much a key delineator and differentiator, is the cardiac tamponade and the exsanguination group. So there was marked difference, as you said, within survival rates, depending on cause of traumatic cardiac arrest. Why did you analyze the results separately into these two domains of tamponade and exsanguination?
Yeah, so traditionally everyone looks at penetrating and blunt trauma, and we initially started looking at the data and that approach, but then we started to really realize that two things. One, within the blunt patients, there's actually patients that had penetrating trauma, so they had tamponade, not penetrating trauma, they had a tamponade, and then the bulk had a sanguination. But those patients who had tamponade behaved more like the patients who had penetrating trauma and had tamponade. And the patients that had penetrating trauma and a sanguination behaved more like the blunt trauma patients. And it really sort of, we started to see that actually what mattered more is the physiology of what's causing the arrest rather than the actual mechanism of injury. So we really started to hone down and say that this is what really needs to decide to drive decision making, because it matters less in our approach in terms of what our treatment decisions will be, whether the mechanism, it matters what's the underlying cause of that arrest. And, this is what we've thought about forever when we think about shock and the different types of shock. But when it comes to resuscitative thoracotomy, we kind of went back to this mechanism of injury kind of approach. And so, I think it really matters a lot because we know resuscitative thoracotomy is highly effective for tamponade, but it's not effective and potentially even harmful in the patients that have a sanguination. We really need to think about stopping the bleeding, being able to repressurize their arterial system to have diastolic myocardial perfusion in order to get ROSC again and resuscitate, or more importantly, in that sort of circulatory arrest, peri-arrest sort of phase, to really intervene early in the tamponade patients to relieve their tamponade, and in the exsanguination patients to arrest their bleeding and resuscitate them with volume. And those are very different branches that you go down. So, and you can't just lump every patient with penetrating trauma into one group or the other, because they really have different underlying physiologies and different underlying approaches to treating those physiologies.
So we were just talking offline actually about you meeting with some of the team to talk about the what now. So what does this mean, and how does this change systems and a system approach really, Mike? You're right, depending on physiology, depending on the pathology in front of your face, what now? And one of the aspects I'd really like to drill in and get your thoughts on, Mike, would be, if this really mandates a shorter decision time and indeed shorter window to intervention for thoracotomy, what are the implications for teams? And indeed, I guess, what system changes have to take place to facilitate those interventions?
Yeah, so I think a few things. One is that so system changes, we can't just treat this superficially and think about it in simple terms, that there's a complexity there, and we have to embrace the complexity and develop a system that has the rigor to deal with complexity. And that often means teams that are more sophisticated and able to deal with that degree of complexity. A big piece up front is early recognition and early dispatch. That is absolutely critical for both cases, the sanguination or tamponade, but really recognizing the seriously critically injured patient and mobilizing resources to them as fast as possible, because in both groups, time is of the essence. And then for the tamponade group, it's really trying to differentiate patients into high likelihood of tamponade or high likelihood of a sanguination. Also, we know that patients have mixed pathology do the worst. So if you have tamponade and sanguination, really, you have to, they're a different sort of patient group, and managing the exsanguination first, volume and stopping their bleeding is really critical. But with the patients with tamponade, it's really push on quickly, go to tamponade, and how to move that forward, unless you have really significant red flags for saying that this is a futile case. It's been way too long, because we know time is a big factor here as well, but that sometimes that's difficult to ascertain on scene. But really act quickly in terms of getting on with the thoracotomy in the tamponade cases. And in the exsanguination cases, it's really focusing more on damage control, pre-hospital resuscitation, which the LAA team is about to has already shifted their protocols to, but we'll be publishing more on and sharing more in the near future about that. And that's really looking at access, large amounts of blood volume, stopping hemorrhage, repressurizing the arterial system with things like Reboa potentially. So those are very different mechanisms, but really probably avoiding thoracotomy in those patients because we think that they're less likely to benefit from it. So it's really starting to be able to separate out those two treatment pathways for those patients.
Let's just double click, Mike, and look at thoracotomy for a minute. But I believe London's Air Ambulance really went through an iterative approach to thoracotomy where they decided to distill down the amount of kit for thoracotomy to some of the fundamental components. So almost making the procedural effort and cognitive skill simpler to facilitate quicker procedures, which completely makes sense. But could I get you to speak to some of the challenges, really? Because some HEM services, quite rightly, as you were saying, will deliver thoracotomy, some won't. But could I get you to speak to some of the biggest challenges in performing thoracotomy in the pre-hospital setting compared to that of an emergency department?
Sure. So I think so it's not really the task challenges that I think are as great of particularly opening the chest and whatnot. I think the biggest challenges are designing a system where you can get the team, recognize the patients and get teams to them fast enough. So that's one of the number one challenges. The second challenge is really about what to do once you have the chest open. That it's not just a matter of opening the chest, it's also all the other pieces around it. It's all the non-technical skills of managing a team, of how to mobilize that group, how to do the concurrent therapies with they still need, good access, they still need blood, they still need all these other pieces, and then some of the technical skills of suturing, tissue management, handling, and stuff like that. And a lot of those things are require additional skills. I'd actually, in some cases, I'd say ED thoracotomy in the emergency department has different challenges. First off, it's unless the patient arrests in the department, there's probably not a lot of utility of doing it. This really is in many ways a pre-hospital therapy. And it's a different population that probably makes it to hospital and arrest than the ones that arrest pre-hospitally. So they're different phenotypes. But in the emergency department, with some of the things I see is there's sometimes that there's the lure of, well, we're really close to an OR. Do we do it or not do it here? And then that crowd effect of, well, there's someone else that should maybe do it and waiting. So I think there's different factors between the two locations.
So looking at just the training and competency really involved in thoracotomy, but as you said, it's a high stakes intervention. It's quite rare, but does, like you say, when it's not mandated, it's mandated almost immediately. Could I get you to speak to sort of the training and governance required to ensure that from a system and a provider perspective that it's both competent and confidently performed?
Yeah, so I think Scott, so the governance is really key, and I think that's one of the things that one of my biggest takeaways from London's Air Ambulance is that rigor and the importance of having really good clinical governance and that learning system, that curiosity, continuing to ask questions, look at your cases, reflect, learn, improve your treatments and your system. That's key and really needs to be in any system. Some could argue that we probably shouldn't have waited 20 years to do this big review. We should have done it earlier. That's hard though when you're dealing with small numbers, and that gets to the next piece that is around sort of the volume issue, and that's both difficult for studying it as well as for training the skills. And Harriet Tucker and a group that I'm involved with had just finished a while ago a national registry for a year on thoracotomies done in both the emergency departments and pre-hospitally, and that's soon to be published. And there we start to potentially see some sort of a volume effect in terms of services that do more thoracotomies possibly having better outcomes, but there's other confounding factors, so it's hard to say. But what I think is really essential then is the role of training, simulation, and the ability to manage those, develop those skills. But also a lot of these skills are skills that you need to develop day-to-day things like rapidly obtain access, suturing, handling tissue, and stuff like that. And it's really a lot of those skills are developed you have the volume to do that in hospital, and then you can take that to an out of hospital setting, or you're in some type of practice where you're doing that regularly. So when you get to these high acuity cases and it's ultra time sensitive, you have the ability to really deliver those skills with confidence.
And as you were saying, actually, Mike, just comparing this to other systems, London was a great and is a great test bed for this kind of data because there is a real skill acquisition and utilization and caseload in London with penetrating disease. So it's actually the system itself is seeing a lot of these kind of patients. So it's prudent to be able to pull the lessons learned from this system. But could I get you to speak to how the findings compare with other studies, thoracotomy studies worldwide? And are there lessons in your mind, Mike, that could be learned from other systems?
Yeah, so in first off, we really looked at the data elsewhere, and there are no other comparable pre-hospital cohorts outside of the existing London data. So we had to look inside hospital for to get the sort of the size of cases to be able to of cohorts to be able to compare. And there are a couple of studies. So there's one in the U.S. which is cutely named the Aorta Registry, which is the American Association of the Surgery of Trauma, Aortic Occlusion and Trauma and Acute Surgery Study. Anyways, the Aorta study, and they had 310 patients, and their group was very similar to ours in terms of, I think, the acuity. If you use the number of patients that were receiving CPR at the time of thoracotomy as a measure of severity, how sick they were, as opposed to patients arresting in front of you type of thing. So where they are in their timeline of their pathology. So we had 72% of our patients that were receiving CPR at the time. They had 75%. And their outcomes, survival to hospital discharge for their group was 5.2% overall. For us, it was 5 for all cases. So that's very similar and very comparable and similar rates of good neurologic recovery in the 76 to 80% range in the two studies. So those are very comparable. And then there's a massive cohort from the Eastern Association of Surgery for Trauma Patients, EAST. They have over 10,000 patients with in-hospital thoracotomy. And again, it's in-hospital patients and it's such a broad group. But if you look at their group of patients where they most strongly recommend thoracotomy, which are the ones who have signs of life present initially and then arrest in front of the group, in front of the team, their survival to discharge for their cohort was 21%, and our cohort was 19%. So very similar. And then if you look at a further subgroup of that, of those patients who actually arrest in front of the team, for our LAA teams, the survival, if they had tamponade, so tamponade plus arresting in front of the team, the survival rate was 61.5% for that group. So for me, that really just says that, that it's very comparable, if not even actually better than in-hospital thoracotomy. If you have a tamponade, you get it right away by a skilled team. I think, it emphasizes that you can deliver this therapy pre-hospitally in the right cohort of patients in the right system.
So just looking at interventions which have had quite a lot of focus recently, actually, such as Reboa. Do you see the role of thoracotomy changing in the future, Mike? It seems to be that, like you said, very much from this literature and from the data, that in this cohort of patients in the penetrating disease with a clot, it seems to be the intervention of preference. Could I get you to speak to how you see the role of thoracotomy changing in systems which are delivering the intervention?
In terms of those areas that already are delivering it, I think there's probably going to be more of a focus in that this isn't a treatment for traumatic cardiac arrest. This is the treatment for tamponade, and really focusing on the patients who have tamponade need a thoracotomy. They need it fast. They need it pre-hospitally, and if they're going to survive. Patients who don't have tamponade and have a sanguination, really need to have their bleeding stopped, need large bore access, need aggressive resuscitation with much more significant volumes of blood than most systems carry at the moment or are looking at carrying, and most of that is available in hospitals. So it's a combination of the way it has been before already for these types of patients. It's both early pre-hospital damage control resuscitation, try to get them in a survivable fashion to hospital so that they can then have ongoing care, and things like Reboa and or selective aortic arch perfusion may have a role in those patients, particularly if to help uh, make it feasible to have enough volume so you can you're basically decreasing the patient's circulating volume, so the blood that you do have can be effective, since you just can't bring a whole blood bank with you to the scene. But in order to get a patient to hospital, and that's sort of longer transport times, different environments. So those patients, and to quickly repressurize the vascular system so you can get diastolic reperfusion. So a lot of the work that Robbie Lendrum's been looking at and Zane Perkins have been leading, really looking at taking those skills and focusing those on exsanguinating patients, and really probably doing a lot more work in redefining how we manage exsanguination pre-hospitally, or patients who have almost exsanguinated even better, because those are the ones that are the most viable.
Yeah, indeed. And actually, just looking at that, it seemed to be, to your point and to the data, the exsanguination group, once they'd gone into cardiac arrest, getting them out of cardiac arrest was extremely difficult. And almost, I think that the survivorship was completely minimal. If you could just speak to that, actually, because like you said, once they were in cardiac arrest within the exsanguination group, there seemed to be almost 100% mortality.
Yeah, that's 100% mortality. Well, it's like 98% mortality to hospital discharge. There's actually a much higher rate of ROSC and survival to hospital in that group. So there's two pieces to that. One is a question about, is thoracotomy, because we're only looking at patients with thoracotomy. That's the starting point. We're not looking at all patients with sanguination, although a significant number of them receive thoracotomies in the current, or did in the London system. That's changing. So in those patients, thoracotomy is not necessarily the right treatment for them. But a lot of them did still have ROSC and get to hospital. So it's how do we continue to advance the system in hospital, the whole system of care for these patients, to get them to that point of survival with a good neurologic outcome and quality of life. And that takes, if you just stop up front, you're not going to ever get those patients there. So it's looking at the whole system and then really targeting the right treatments for the right physiologic indication is really, I think, where we're driving home with this paper.
So, Mike, just looking at some of the ethical considerations, could I get you to speak to maybe how we balance the potential for survival with the risk of, in a way, prolonged resuscitation efforts, particularly in the pre-hospital environment?
Yeah, so I think, and this is one of the things we've been talking a lot about sort of internally, is how, in this next publication that we're working on, which is how do we apply this, and how it is being applied, and the changes that are occurring inside the system in London. I think there's definitely a recognition that that time is of the essence for these patients, and particularly in the tamponade, you need to intervene early, and if you go past a period that's too long, you're getting into a point of futility for them. So it's how do you design a system and get the teams there. And then for the sanguinating patients, yeah, there's lots of or some recent publications out that look at the lack of utility of doing things like chest compressions in patients that have empty hearts. That really it's about stopping the bleeding, filling them, and you do have to make a decision at some point. And I think this is where sort of where the ethics pieces are starting to come in, are around, especially when you have a finite resources such as blood, how much do where are the decision points to say, okay, we're going to use all this resource in this one patient when, there might be another stabbing in 5 minutes or down the road, and starting to get that balance. And I think, some of the data that's coming to this around time, and we're drilling down and looking at when do we stop seeing really any sort of ROSC in these patients, not only just the long-term survival, but any sort of effective ability to resuscitate them, and starting to try and use some of that data. But at the same time, I think there is this need that we have to not be too sort of fatalistic about this, or will be back where I was when I started my journey to London of saying, well, we're not even going to try because it's futile, and then you won't have good outcomes.
Just looking at protocols, Mike, as we start to come into land, how should this data and indeed the results from this study really change, and should they change prehospital trauma care protocols based on the findings?
Yeah, I think so. I think one of the things that people are starting to become really apparent to that for tamponade, particularly, scoop and run doesn't work. So the idea of scooping and running someone who's having a pre-hospital arrest to hospital for in-hospital thoracotomy is not going to be effective. If you're going to treat that, it has to be treated on scene, and you can't until we have the transporter, we can beam patients up to the ER. Those times aren't going to work. Um, for the for the patients that are sanguinating, we really need to look at, again, getting a team to them that can help them survive to hospital. So with sufficient ability to get access, amount of blood, and rapid still extrication to hospital, potentially endovascular interventions to help them get through that journey to hospital, particularly if you have longer distances and longer travel times. So I think those sort of relooking at the system and really asking the questions, asking what preventable deaths are occurring in your system, and then using that to be able to drive. And there's good papers, work by John Holcomb and others from places even in the US where they have, in highly urban centers, seeing between 10 and 20+% of patients would have potentially preventable deaths pre-hospitally. So there's a need to drive some of these interventions in those areas earlier in the patient's care, but target them appropriately to their physiology.
And so just finally, Mike, if we could just get your reflections, actually, just indeed your personal reflections, and how being involved in this research and seeing the results, how it sort of shaped your perspective on penetrating disease.
Yeah, so I think a couple things. One, working with LA has caused me to reflect deeply on my practice in general, not just in related to penetrating disease, but really asking the questions around are we creating self-fulfilling prophecies in some of these cases? So if we never really treat or effectively treat a traumatic cardiac arrest like tamponade, if we're not really doing looking at ways to deliver things like pre-hospital thoracotomy, then yes, we're going to see 100% poor outcomes. But similarly, and this is what makes it more complex, is that if we are doing the wrong procedure for patients, like thoracotomies on patients that are sanguinating, when probably a better management strategy is required, well, again, we can be creating a self-fulfilling prophecy. We may not be seeing the benefits in terms of the other therapies in those patients we could. So it's really that reflecting on what you're doing, thinking about back to physiology, thinking about what can be done, and in order to really move the dial on preventable pre-hospital deaths, and then thinking about system design, not just the technical skills of doing it, but really how do you build a system? How do you build the teams? How do you teach people the other skills they need, the non-technical skills, the decision-making skills to be able to deliver these types of therapies effectively? Yeah, like everything, the more you get to know about it, the less black and white it is, the more gray it is, and the harder it ends up being. Unfortunately, there aren't a lot of simple answers out there, and just the need for us to be able to to set our egos aside, set territorialism aside, to collaborate across professions and specialties to really help patients together is, I think, my big takeaway.
Listen, that's fantastic, Mike. Fantastic. And to your one of your main points is the power really is in, like you said, stepping outside of your comfort zone and being involved in other high-performing teams across the world where you can really garner, and you said it yourself at the start of the interview, just stepping away from your practice in one area just really helps see and involve data and research and indeed perspectives from another system, and but integration of those lessons learned back within the systems wherever you are can be powerful. So there's something really to be learned from this data, from this research. I think it's extremely powerful. It's the widest, biggest data set globally for this disease type. And just to really emphasize your point around, this is a real mindset change around pericardial tamponade. It's not an intervention for traumatic cardiac arrest, it's an intervention for pericardial tamponade, and again that's a shift which, like you say, you can hopefully see within the patients and indeed the sequelae and the survivability, and that's a real mindset shift, Mike. So it's fantastic just to get that. It sounds like semantics, but it's really not. It's actually targeting the intervention far more precisely, which makes all the difference.
Yeah, I totally agree. And I guess the last big lesson is the importance of collaboration and teamwork in doing this. It's very difficult for few services have the volume of London to do it. We have to work together across systems, across HEMS services, across the UK and the world to do this. And just the privilege and pleasure and how much I've learned from my colleagues, Gareth Davies, David Lockey, Zane Perkins, Robbie Lundrum, and the others that are not just the physicians, but yourself for sure in working together, but also Andy Whitehouse, Dean Bateman, so many of the great paramedics in London's air ambulance that really have learned so much together with, and both in working and tackling problems like this. And yeah, just to say thanks to all of you.
No, listen, it's definitely, like you said, it's a collaborative effort, and it's fantastic to get your thoughts on this, actually, Mike. But listen, it won't be the last time we have you on the podcast. It's fantastic just to get you back on and get your thoughts. We'll link the paper in the show notes so people can go away and read it. But it just leaves me to say thank you, Mike.
Oh, thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.